Many thanks for the kind introduction. A very good afternoon to everyone. On behalf of the College of Anesthesiologists and Intensivists of Sri Lanka, I take this opportunity to thank the organizers for having me invited to the session to represent Sri Lanka. The topic of my presentation is Holistic Assessment of Cancer Pain, Points to Ponder. This slide shows the outline of my presentation in the next 20 minutes. Very briefly on the burden of cancer pain, the close relationship between the biopsychosocial aspects of the individuals and the cancer pain experienced, the total pain experience, and finally, how the cancer pain is best assessed in achieving improved or better pain outcomes. The prevalence of cancers, the global and regional experience. According to the World Cancer Report 2020, the prevalence of cancers is rising rapidly throughout the world, and the burden is
Assalamu alaikum wa rahmatullahi wa barakatuh. This is Abdullah Abul Khair. I'm giving a talk about spinal cord stimulation, a review. This is in collaboration with King Faisal Hospital Department of Anesthesia in our cadaveric interventional pain course that will be done at Al Faisal University. I'm a consultant anesthesiologist and chronic pain specialist and consultant, and will
Session 3 started. Learned delegates, it's time to start our next session, which comprises 3 presentations, 15 minutes for each speaker, followed by discussion. And this session will be chaired by distinguished scholars and welcome 4 legendary personalities to come up on the stage and chair the session. Professor Dr. Debabrata Bonik, Dean, Nursing and Medical Technology, Professor, Department of Anesthesia, Analgesia and Intensive Care Medicine, Bangabandhu Sheikh Mujib Medical University, President, Bangladesh Society of Anesthesiologists, Critical Care and Pain Physician, Secretary General, SARC Association of Anesthesiologists, Dr. Nirja Bharti, MD NMS, Professor, Department of Anesthesia and Consultant Pain Clinic, PGIMER, Chandigarh, India. Dr. Guru Murthy, MBBS Stanley Medical College, Chennai, MD Anesthesiology, Chhatrapati Shahuji Maharaj Medical University, Fellowship in Interventional Pain Practice, FIPP, WIP from USA, Course Director, Hands-on Training in Interventional Pain Management, Dr. Guru's Interventional Pain and Palliative Care, Trichy, author and co-editor of books, number 1, How to Start and Run a Pain, number 2, Common Pain Management, Procedures, video book volume 1, 3, Common Pain Management, Procedures, video book volume 2, number 4, Clinical Methods in Pain Medicine, and number 5, Essentials in Pain Management. Dr. Wahiduddin Mahmood, First Associate Professor, Department of Anesthesia, Analgesia and Intensive Care Medicine, Bangabandhu Sheikh Mujib Medical University. First Secretary General, Bangladesh Society of Anesthesiologists, Critical Care and Pain Physicians. I would like to request honorable chairs to come up on the stage and have their seat. Thank you. Now, I would like to Dr. Gayani Walpola, Consultant in Pain Management Unit and Anesthesia at National Cancer Institute, Maharangama, Head Faculty of Pain Medicine, author of Pain Chapter, Non-Cancer Palliative Carcinoma Manual in Sri Lanka, contributor for Cancer Pain Management Guidebook in Sri Lanka, for Sir's presentation. আমি আর বলবো না।
Coping up strategies, social factors, and especially other illnesses like cancer. But are we giving due respect to the brain perception and the brain modulation in the management of pain? Do patients aware the importance of this modulation? Every day we see among our patients pain as a symptom or a disease. How do they develop this disease? It could be the transition from acute to chronic pain is associated with structural plasticity or circuit reorganization at various points in somatosensory circuit. Peripheral sensory neurons and axons exhibit diverse types of structural changes that are specific to different types of chronic pain. The structural remodeling of synaptic contacts of spinal dorsal horn neuron is causally associated with nociceptive hypersensitivity. Neuropathic pain is associated with the reorganization of cortical sensory hubs. Chronic pain is characterized by increased pain-related activation of emotional network in the brain. Pain disrupts structural and functional brain connectivity, which can be restored with effective treatment. Anyway, chronic pain is a state of continued suffering sustained long after the initial inciting injury has healed. So, obviously, they can have neuropathic element or nociplastic pain or both. These are the common examples that we see in our day-to-day practice. Different types of chronic pain or other different types of pain may be cancer-related pain, or surgical, or traumatic, chronic secondary musculoskeletal, visceral, chronic neuropathic pain, or maybe secondary headaches. Chronic primary pain is pain that cannot be better explained by any other chronic pain condition. In the development of chronic pain, in the structural remodeling, peripheral and central sensitization and neuroplasticity is identified. What is neuroplasticity? Neuroplasticity is the ability of nervous system to change its activity in response to intrinsic or extrinsic stimuli by reorganizing its structure, function, or connection. What is nociplastic pain? The pain that arises from the altered nociception despite no clear evidence of actual or threatened tissue damage causing the activation of peripheral nociceptors or evidence for disease or lesion of the somatosensory system causing the pain. Okay, now I am on the track. Brain and pain. Are we practicing brain pain modulation optimally in patient management? Are we taking optimum precautions in the prevention of neuroplasticity and chronic pain? Can't we use neuroplasticity in the treatment of chronic pain? Can we reduce drug prescription while in the treatment of pain by above. Essentially, 6 key main mechanisms have emerged which are involved in chronicity of neuropathic pain. Cortical reorganization and maladaptive neuroplasticity, activity increases in primary nociceptive areas, recruitment of new cortical areas, modified endogenous pain modulation, the neurochemistry changes, structural changes of the cortex. Cortical reorganization and maladaptive neuroplasticity. So we talk about when we manage phantom limb pain. The cause is particular cerebral reorganization phenomena and cortical remapping. This is how we can explain and illustrate the cortical reorganization in neuropathic pain. Activity increases in primary nociceptive areas. It is not the pain center. The nociceptive inputs activates a complex area in the brain. Primary nociceptive areas are often known as pain neurometrics. We all know pain neurometrics consist of primary and secondary somatosensory cortices, insula, the anterior cingulate cortex, ACC, prefrontal cortex, thalamus. So this is the MRI. These cortical areas around the sylvius fissure in the human brain, in the MRI. The altered cerebral activation pattern observed in the neuropathic compared to the physiological nociceptive pain can be divided into 2 basic phenomena. Number 1, increasing activity primary nociceptive area, so-called pain matrix. Number 2, recruitment of additional cortex areas, regions of the brain that are not members of the pain matrix primarily. For the classification of symptoms of neuropathic pain and imaging study, we can distinguish between spontaneous pain, which may be continuous or paroxysmal, evoked pain, which could be dynamic, mechanical. This is the cortico-limbic structures association with chronic pain. This model regarding the brain circuits and its transition from acute to chronic pain. This is the cortico-limbic structure associated with chronic pain. The brain structure, the well-identified brain structures are medial prefrontal cortex, amygdala, periaqueductal gray matter, anterior cingulate cortex, hippocampus, and the nucleus accumbens. So I'm not going to talk all these things in detail. The prefrontal cortex, anterior cingulate cortex, that is ACC, amygdala, hippocampus, nucleus accumbens, and the periaqueductal gray matter. The recruitment of new cortical areas. Beyond the neurometrics, individuals' pain signature is influenced by multiple factors such as underlying pathological pain condition, their expectation, attention, affect, and mood. These areas include frontal cortex areas such as dorsolateral prefrontal cortex, as well as slew of brainstem nuclei, which are involved in modulating pain networks. In the model of the cold hyperalgia induced by menthol, activation of the nucleus of the brain system, which can be illustrated in this diagram. The brain activity for chronic pain shifts away from the pattern shown for pain in the more prefrontal and limbic circuitry. These are more examples. The modified endogenous pain modulation. In patients with neuropathic pain syndrome, researchers and imagers endogenous pain modulation by attention, cognitive or emotional processes are still outstanding. However, it is assumed that basic mechanisms of pain modulation by healthy volunteers on patients can be transferred. The neurochemistry changes. Two methods of functional imaging allows non-invasive investigation of regional neurochemistry in the human brain, which I'm not going to talk in detail. And the role of neurotransmitters in chronic pain. Binding of neurotransmitters to their receptors on postsynaptic neurons influence pain transmission could be inhibitory or excitatory, such as microglia and astrocytes release various neurotransmitters. This contributes to the development and maintenance of chronic pain by activating or deactivating nociceptive neurons in the central nervous system. There are so many neuropeptides have been identified, and these play various roles in the formation, transmission, modulation, and perception of different types of pain. These are glutamate, which is an excitatory neurotransmitter. GABA, gamma aminobutyric acid, is an inhibitory neurotransmitter, which is an inhibitory neurotransmitter in the central nervous system, and well-known opioid peptides. The structural changes of the cortex. The structural changes of cerebrum in vivo can be measured with different techniques. Further studies with large number of cases, advanced methodology will show whether there are characteristic patterns of changes of the cortex in individual diseases. The role of learning and brain plasticity. The chronic pain is a consequence of plastic changes in cortical circuitry, leading to new learning and to memory formation that are continuously reinforced and cannot be extinguished as the consequence of the emotional and motivational association with the painful stimulus, perhaps coupled with enhanced learning abilities due to a predisposition to addictive behavior. Pain is less somatic and more affective in nature when this happens. To understand the role of brain and associated learning mechanisms in pain. Chronic pain is a state of continued suffering sustained long after the initial inciting injury has healed. Chronic pain is a persistence of the memory of pain and the inability to extinguish the memory of pain evoked by an initial inciting injury. There are so many articles published regarding this neuroplasticity, and out of this all the studies, there are strategies to enhance neuroplasticity, whether we can use this as a treatment to relieve pain, to relieve chronic pain. Techniques that reopen and stimulate neuroplastic responsiveness in the central nervous system may be pharmacological, may be transcranial stimulation methods such as transcranial direct current stimulation or transcranial magnetic stimulation, or maybe behavioral and lifestyle strategies like exercise, incremental training, education, different video games, caloric restriction, intermittent fasting, and glucose administrations. They have done so many trials regarding this. And this is one known trial. And also, we need more emphasis regarding brain modulation like mindfulness, meditation, lifestyle modification, yoga, and there are so many other brain changes with a long-term excellent understanding and a patient education. These are my referrals. Finally, the summary. Chronic pain is a state of continuous suffering sustained long after the initial inciting injury has healed, maybe more than 3 months. Neuroplasticity is the ability of the nervous system to change its activity in response to intrinsic or extrinsic stimuli by reorganizing its structure, function, or connection. Essentially, 6 main mechanisms have emerged which are involved in the chronicity of neuropathic pain. There are strategies to enhance neuroplasticity as a treatment of chronic pain. Thank you very much.
Okay. Am I online? Right. Thank you, Dr. Gayani, for an excellent presentation. We'll come back with discussion and question answers after we have another speaker who is already ready there. I would just have the pleasure of introducing, this is Thomasi Makoloa, right? Am I right? No? Sorry, we have the 4th speaker now, which will be Amani Ayat. Okay, she's professor of anesthesiology, ICU and pain, Cairo University. Right? Can you hear me?
Yeah, sure. Do you
Right,
hear
sure.
me well?
Yeah, I'll just introduce you for give me 2 minutes. Yeah.
Okay, I will.
Okay. She's Amani Ayat, professor of anesthesia, ICU and pain, Cairo University, and the head of pain management in Dur Al Fawad Hospital, Cairo. She's the general secretary of the African Society of Regional Anesthesia and Pain and chair of the Middle East section of World Institute of Pain. Today, she'll be speaking on safety in chronic pain intervention, and the time will be about 20 minutes. If Dr. Amani, it's now over to you, please.
Okay, thank you very much. Thank you for the nice introduction. Good afternoon, everybody. It's a great pleasure to be with you again. You know, it has been always my pleasure to be with you. I've witnessed the birth of this esteemed conference, and thanks to the organizing committee as well. So my topic to you is about safety during pain management intervention. Rule number 1, as we learned long ago, is cause no harm. Pain management doesn't allow us for a minimal harm if we can avoid. So let's define what is a safe pain practice. Safe pain practice is not causing harm or injury, of course, having a low incidence of adverse reactions or significant side effects. If we follow the adequate instructions that were given for the intervention or the drug or whatever, having a low potential for harm under a condition of widespread availability. First, let me remind you of one devastating article from 2012, fungal meningitis related to contaminated epidural steroid shots. And this was reinforced by another article from The Lancet at 2013. And it was talking about that they found a contaminated form of epidural steroid, triamcinolone acetate, that was produced preservative-free. And after, spreading like 17,000 vial, they realized it was contaminated by fungus, which is a heroic, devastating something. By that time, by the article of The Lancet, there was like 700 patients diagnosed with clinical or subclinical fungal meningitis. And also there was like 51 deaths. So as you see here, sometimes our pain management intervention can really end up dramatic. Another eye-opening case report that was published in the Journal of Anesthesia, again in 2012, a catastrophic complication of an interscalene catheter for continuous peripheral nerve block analgesia. This patient, a young patient from Hadassah University Hospital, who had an interscalene catheter placed for a shoulder surgery. And he was put under general anesthesia, light general anesthesia. He was okay. He was doing okay, not in need for any analgesia early post-operative. So they didn't initiate the infusion. And once he was transferred to the unit at night shift, he started to complain of pain. They called the anesthesiologist who gave a bolus. In the morning, they found the patient shocked, arrested maybe for 4 hours, and cyanosed. And by autopsy, they found that the interscalene catheter migrated through the foramen into the epidural space as if you're giving him a very high epidural without any help. So complications of pain management intervention are devastating for the patient, devastating for the physician, but often avoidable. So our role here to highlight how can we avoid. Complications are commonly technique related or injected drug related or improper technique or mistaken site of injection. I decided to inject here and I injected in somewhere else. How to minimize the technique related complications? A huge improvement happened when we started using the image guidance. Image guidance with contrast enhancement, increased precision, increased safety, increased comfort for the patient, a better outcome, a better science, and new procedures, of course, became created. What about the ultrasound guided techniques? Ultrasound is the gold standard for soft tissue. So you can see, of course, the vessels, the blood by Doppler. You can see the muscles, the tendons, the nerves. So you can see exactly where you are. As regards the drugs to be injected, local anesthesia. And of course, as anesthesiologists coming from a background anesthesiologist, we are familiar with the local anesthesia toxicity. Let me remind you very few facts. Maximum single dose for infiltration with lidocaine, which is the most commonly used, is 300 milligram per shot, which means 30 cc of 1%, which is, by the way, if you let yourself comfortable, you may exceed that. But for the bupivacaine, 70 cc of 0.25% is a little bit risky. So you have some safety margin with the bupivacaine. Toxic plasma levels for the lidocaine is 5 microgram per ml, for the bupivacaine 1.5 microgram. Cardiac toxicity is greater with bupivacaine and CNS toxicity is greater with lidocaine. What about the steroids that we inject? Let's highlight something. Side effects from steroids during spinal injections are uncommon, by the way. No evidence of deleterious effects about intrathecal steroids injection, but we don't have enough articles to support the utilization. There have been reports of systemic effects from steroids from the absorption. Like hypertension, increased blood pressure, hyperglycemia, nausea, headache, insomnia, flushing, rashes. I think we as pain management intervention doctors were familiar with some of these. One of my patients was extremely sensitive to glucocorticoids, and by the way, she was middle-aged and she was medically free. Every time we have an injection, she had the second day something like pulmonary edema that was relieved by diuretics only. So be aware that it's not common, it's not very common, but you might find one patient who is extremely sensitive to what you are injecting. However, for patients at risk, like patients in heart failure or hypertension or uncontrolled diabetes, we have to lower the dose. This formula is our limit in our practice, is from triamcinolone or depomedrol, 3 milligram per kg per 6 months per kg, which means whatever the number of injections you're going to supplement for your patients, please try not to exceed the 3 milligram steroid per kg in 6 months. Improper technique, and this is a dilemma. Our nightmare is intravascular injection. Local anesthesia toxicity, if you are intravascular, can cause seizures, CNS toxicity, or cardiac effect. But whenever we're dealing with, the cervical and the intracranial whatever, or head and neck injections, there is a higher risk of toxicity, even from the minimal dose. I mean, if you're going to have a transforaminal cervical injection, you know that the vertebral vessel is here. 0.5 ml of lidocaine can cause seizure, 0.5 ml. So you have to be very cautious whenever you're dealing with the head and neck. Another thing is barotrauma or compression to a nerve or the spinal cord. Injection into a nerve or spinal cord can cause a damage. So we have to know where is your needle tip and understand the anatomy. By the way, I brought you this picture because it's a good example of patients having marked compression by this. Look at this white marks in the spinal cord. It means a real complication, a real compression. So if you add like cervical epidural here, whatever the volume you're going to inject is 4 ml, 3 ml, it might add to the pressure. So be aware of the mechanical trauma. But we have also the chemical irritation or chemical trauma. Injection into or around the nerve, as we said before, can be toxic and hazardous. To avoid that, know what you are injecting, the proper dye, the proper drug, the proper dose. Read the labels and draw up your own medicine. This is my gold standard. I never inject anything from any ampoule that was prepared by somebody else. And I want to tell you a story because in my practice, we wanted to issue a JCI accreditation for our pain management unit. We went through a huge process of improvement. But one of the criteria that the JCI, just JCO, insisted on to have a label on the high alert drugs. And they considered all the injected drugs in our practice is high alert drugs. So we kept going to and through, resisting, trying to do something different, but eventually we could have a label pre-printed and we put it to sterilize, and then we could add it to a sterile syringe. But you can have a sterile marker. And I give you another tip from my own practice that I have a color coding at size local anesthesia that I infiltrate the skin with. Commonly, it's lidocaine 2% in a 10 cc syringe. For the dye, it's always a clear, it looks like the Omnipack, it looks like a clear fluid in a 5 cc syringe. So now I have a size coding. What about that triamcinolone or other drugs? Amcinolone is whitish in color. So the proper injectate that you will leave finally in the nerve, in the epidural space, wherever, will be a white. Any other drug that I'm going to inject, I prepare in situ whenever anything with anything else. It can help somebody if this information can be of a value. In real life interventional pain, we have to be prepared. For example, for cervical epidural, I step in the room with a ventilator ready behind me with all the emergency drugs available in ampoules on my tray. Because whenever you need it, you don't have the time to search for it. So you have to be prepared. Number 2, anticipate problems. Number 3, react appropriately to an emergency and don't be shy to call for another help. So a prepared facility and personnel is very important. You should have a crash cart, suction, a defib, medications, trained personnel, and transport plan in place. If you need to transport your patient, you have to be prepared. Anticipate whenever you have an increased risk. When do we have an increased risk? For a post-surgical anatomy, obese patients, chronic severe medical condition, in the elder, in the head and neck procedures, all of them you have to be prepared. And of course, if you have an inexperienced interventionist, he has to have a lot of support. Look at this image. Can you believe that sometimes you can put your needle here in order to have a stellate ganglion block, or you can have your needle here to have trigeminal ganglion block? So look at this, how cumbersome it is. It shows how risky what we are doing. How to avoid intravascular injection? It's very important. Suction before injection, but I want to tell you, most of the places where we inject, for example, epidural space is a negative space and full of veins. So whenever you suck, most probably you're going to compress the vein. So don't rely very much on the backflow of blood that you can see. It's not always, visible. Use an imaging aid, which is very important. Ultrasound guided with color Doppler is mandatory if you can use it. The C-arm, but use this digital subtraction technology. What is the digital subtraction technology? I found out that there is what we call a digital subtraction technology in most of the recent C-arms, but we don't know how to use it. What is digital subtraction? It subtracts from the image the bone. Look at this picture on the left. This is a patient with fixation. Look to the right, we have subtracted by this option the bone. Now you can see exactly the dye, and if there is a minimal subtraction, at least in the head and neck procedures. Spinal cord injury, can it happen? Yes, it can happen by direct needle trauma, by barotrauma, by hematoma, abscess injected medication, or chemical trauma, irritation by a used drug that you shouldn't use there, or by infarction. Some of the interesting articles that kept accumulating, a lumbar transforaminal epidural is an everyday job. There was an article in the year, I think 2005, and it kept accumulating about paraplegia following transforaminal in L1. At least there are 4 incident reports about 4 patients who caught paraplegia after L1 lumbar transforaminal. So my piece of advice, whenever you're doing L1, either you use non-particulate steroid, or you use, or you don't do it, just go, epidural, go more center. Why is that? Because the artery of Adamkiewicz sometimes apparent and it comes here. So if you're going to inject a particulate steroid, it can sludge and cause infarction, paraplegia. I thought this is the end, but I was astonished during my search that the Anesthesia and Pain Medicine 2021, there was another article about an ordinary transforaminal, low transforaminal epidural steroid in an elder guy, 70 years. And he caught paraplegia immediately after the procedure. By autopsy and by, not autopsy, sorry, by diagnosis, they found there was a coda equina. It was a huge compression, and even the drug that came from the foramen added to the compression and caused more and more compression and coda equina. That's why you have to be very careful. These are some of the images that I have. Just to remind you, this is an ordinary Omnipaque filling in the epidural space. It's fluffy, it's central and peripheral. And this is from the lateral, okay? Look at this. What do you see here? It's central, it's dense, and it's shooting up. This is an intrathecal spread of Omnipaque. And this is the lateral. What about this one? This is one of my interesting cases, a failed back surgery. I was adding the drug from here, the Omnipaque from here via a catheter, and I found this very thin, spread very high. I just injected 1 ml of the Omnipaque and found this. I kept tracing, by the way, it went as high as dorsal 7. What is that? Can you guess? This is subdural spread. Imagine that with a minimal dose subdural, in the subdural space, you can catch a very high epidural. If you're planning to give the patient like 8 ml or 9 ml in a caudal epidural, and you code the subdural space, you might end up with a total spine. So be very careful. When in doubt, pose has another image, oblique, lateral, do another image, inject further contrast, inject a test dose of lidocaine, consult a partner, cancel the procedure, observe the patient. You have to do all of this. Before I finish, my last information about the PCA, because in our developing countries, sometimes we use it as an intervention. People believe it's a kind of intervention. PCA is a wonderful tool, and it helps the doctors, it helps the nurses, it alleviates a workload. Commonly, it's used with opioids. Lots of advantages and disadvantages. But what about the safety consideration of that? Check this report about the errors that happened with the PCA, we found the bigger incidence with improper dosage, unauthorized drug, omission error, prescribing error, wrong administration, blah, 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 you know, everything. But what counts to me when there is a report about errors that happen, we found that device-related events like 79%, but operator error still there. So be careful during actually the moments during programming, because a 0 to the right or to the left can change drastically the dose that you're going to give it to your patient. One of the interesting reports about the errors that we had in this report, almost 50% of the errors were operator dependent. So be careful. Another interesting article about collecting, you know, the FIMIA, the failure mode of analysis that is done by the quality people. They collected from the manufacturer all the reports, and they found that the background infusion was incriminated, continuous infusion was incriminated in 48% of the deaths that happened from the PCE. So be careful. To conclude, our intervention is minimally invasive, but maximally dangerous. How can you avoid complications? Get the best training available. Learn anatomy and safe injection techniques. Learn to recognize and avoid problems. Become extremely good in what you are doing. Don't be a maverick. You're not a hero, and you'll never be a hero at the expense of your patient's life. Practice within your capabilities. Know your limits. Gain experience and expand your experience gradually. And finally, evaluate your patient. Get a patient history. Patient history might help you a lot about everything. I wish you a safe pain management. Thank you very much.
Thank you, Dr. Amani, for an excellent presentation on safety and chronic interventions.
Thank you.
Right. So I think now we can have certain, if there are any questions from the crowd, if the audience, is our first speaker still online? So, okay, with the, I think the floor is open to both the speakers. Dr. Amani and Dr. Gayani Wolpert, they are both online. So if anybody has any questions, I think. Doesn't seem that we have any many questions.
Yeah.
It seems that everybody's understood everything. Right. First of all, then I think maybe I'll say something. Not a question, but first I would like to thank Dr. Gayani for her excellent presentation on chronic pain. And as she talked about neurochemistry, neurotransmitters' role in chronic pain, structural changes on the cerebrum, especially on the gray matter, and the brain plasticity. Pain, one interesting was pain is less somatic and more effective. That's one thing I liked about her talk. And chronic pain, it's the inability to forget the initial pain response. That was a good thing she had said. And how we can prevent this pain. I think chronic pain strategies to enhance plasticity of the brain, response of the brain, is by increasing lifestyle changes in addition to pharmacological changes. These are the interesting things there. Thank you very much again, Dr. Gayani, for an interesting talk. Dr. Amani, safety, she talked on safety in chronic pain management. And the first and foremost thing, I think, which is almost a Bible for us, cause no pain, no harm, and reduce the reductions. That's very, I think every anesthetist or every pain interventionist should be right. Any doctor should know that. You cannot do any harm. If you do not know what to do, please don't do it, but don't do any harm. Right.
Yeah,
and
that's
if
correct.
you have to, right. And if you have to do it, you should be careful that the adverse reactions are at the minimum, right? Another interesting thing she talked about was in the 2000 Lancet 2012. Dr. Amani, I was very interested in that also, you know, the fungal manifestation of steroids. In more than 700 people, patients affected. That was quite a high number. 700 people. Yeah. And another in 2012, catastrophic complications of the interscalene catheter, the migration. That is really devastating. That was where
you know what? After the interscalene catheter incident, We have changed it. You have a regulation and a standard of care for every technique. For example, neuroaxial is not like peripheral nerve block, but after this particular information, we raised and we called for raising the care level and the follow-up level of interscalene to the level of neuroaxial. The frequency is higher in monitoring, the hemodynamics, the respiration, everything, the warning to the patient, the warning to the surrounding. Actually, we had some benefit from that. It's devastating, but actually you learn something from that.
Yeah, but a very high cost.
Yeah.
Thing is,
Yeah,
sure. But nobody was monitoring that patient. When they found out in the morning, it was almost 4 hours late.
As per there was a comment from the editor, chief editor in anesthesiology on this report in particular, because he acknowledged the courage of the doctor who sent the incident, despite everyone is asking the same question: where are you? I guess what happened that when it migrated, it caused some difficulty in breathing, but because it's cervical, so his hands are anesthetized, sorry. So he couldn't press the button, he couldn't call somebody. And since he was 30 years medically free, doing a minor procedure in the shoulder, no one ever in the world thought of this. But I guess there is a lack of monitoring since 12 a.m. to 6 or 7 a.m. when he was caught, arrested. So yet still we need to learn.
Right. Yeah, definitely there was some lack in monitoring. It can't be gone. Anyway, as you have already said, that for prevention, we can take in certain steps, such as image guided things, know about the local anesthetic toxicities, and steroids. That was one interesting, 3 milligram per kg per 6 months.
Yeah, from the Amphenol, or Depo-Medrol.
Okay.
It's better not to exceed that. And by the way, there are some articles about that selective nerve root can be done efficiently by only 20 milligrams.
Okay.
20 milligrams of steroid. So why to raise it to 80? I mean, if we're going to do a single selective nerve root, we can use the 20 milligrams. If you have 2 nerve roots, you can use the 40. There is 40. No meaning to increase the dose for nothing.
Nothing, right? Yeah, that's interesting. Yeah. That's a good thing, right? And be careful about intravascular injections and barotrauma. That barotrauma of the spinal cord, that was also a very interesting thing. Yeah. Because if you don't know it, you won't look for it. This could happen.
Sometimes I send the patient who is coming for cervical epidural, I send him home because of the difficulty in the anatomy. I'm an old school person. I'm not a fan of selective nerve root, cervical, because it's risky. And having minimal DEXA is nothing. You don't have to come close to the vertebral artery. So my favorite is to go central in the epidural. But when I have much compression, I tell the patient it's extremely unsafe. I'm not going to do it to you. There is no harm. We can send them for something else.
Right, absolutely, absolutely. Another thing was the color-coded syringes. Color-coded, not only for pain interventions. I think every anesthetist should be careful about it. The color-coded things. That's very, very simple thing, but very effective. Color-coded thing. Right. And we should be prepared for complications. Certain times we take it for granted that we don't even do anything. We're just going to put in an injection, but the consequences, like keeping the crash cart ready, keeping the defibrillator ready, all these things, sometimes we overlook that. I think that is very important also. Plus another thing is the digital subtraction. You can just pinpoint where you want to go. That's very interesting. The paraplegia thing in the 2021, where did this happen? You mentioned.
I guess retrograde, they found that there was a lack of, infarction in the spinal cord. And the only explanation that the apparent arteria radicularis magna, arteria radicularis magna is our nightmare whenever we do celiac as well, because it's commonly high. It's dorsal, low dorsal, and commonly on the left side. But they found it apparent in the right side and sometimes low. And what happened in the 2 or 3 incidents, I guess the same, because they found infarction in the spinal cord and paraplegia. Okay. So the only explanation to get this, that through the L1 foramen, there was the arteria radicularis magna. Okay. So either you pinched it so it went into spasm, or by mistake you injected the particulate, because in lumbar we use particulate steroid. And after that, voices were raised that to avoid as much as we can the particulate steroid. Even some people are moving totally to soluble formula. But soluble formula, it doesn't last that much, especially in developing countries. You don't have so many agreement by the insurance for repeated diagnostic block just with lidocaine, and they come. So whenever I'm lower than L1, I use it safely, the particulate. But higher than L1, no, I have to be very careful. Be very careful. The last report from 2021, this is, I'm astonished from it, actually.
That's right.
Through the lumbar transforaminal, they caused the guy codequina. I don't know why. They just add, in transforaminal, you inject 1 ml or 2 ml, but maybe he was about to get the codequina, and you added the last pressure, just pushed it. So he had the codequina.
Was it reversible or was it irreversible?
I think in the what I read about the first 4 articles, it was irreversible. It was irreversible. But the codequina guy, I think he was sent for surgery.
Okay, right.
Yeah.
Right. Thank you, Dr. Amani. Another good thing said, if you are in doubt, take a pause. I think that's very that's a very important for the young generation for us. If you are in doubt, take a pause. You call your seniors, you take your colleague, or even abandon the process. Right. That's very thing.
Yes.
So another nice thing is right. Yeah.
I was trained at certain time by the chairman of Cleveland Clinic, of the pain clinic, one of the old great guys. His name is all over, reports and, literature everywhere.
Yeah.
I witnessed him maybe 2 or 3 times just doing the caudal epidural, and he failed to get into the caudal canal. And he went for, selective root LTF or lumbar epidural. And after he finishes, he met the patient and shook the hand and told him, sorry, I couldn't do the technique that we agreed on, but your safety came first. There is no ego. You're not a hero. You'll never be a hero. You'll only be a hero to save your patient. So don't cause harm.
Right, absolutely. That's very important. There's no scope of heroism. No scope.
Yeah.
You can always fail. Yeah, you can always get out. So
Yes.
Though our procedures are minimal invasive, but the complications are maximum. That's one good thing. And thank you, Dr. Amani, and thank you, Dr. Rayani, both for an interesting talk. I think we can call it close our session this time and go on to the next speakers. And thank you again. Thank you both.
Thank you. Thank you very much. Have a great day. Bye.
Good day. Bye. number session তো আমার থেকে কোথায়? number speaker. Right. Okay. Right. Thank you. So we'll move on to the next speaker. Our next speaker will be Thamasi Makululwa, senior lecturer in anesthesia and a consultant anesthetist attached to the Faculty of Medicine, General Sir John Kotewala Defense University in Sri Lanka. Her special interests are pain medicine, medical education, and sports medicine. And she has several publications to her credit, both in local and international journals. Her topic shall be holistic assessment of cancer pain, points to ponder. Time shall be about 20 minutes. Thank you.
Many thanks for the kind introduction. A very good afternoon to everyone. On behalf of the College of Anesthesiologists and Intensivists of Sri Lanka, I take this opportunity to thank the organizers for having me invited to the session to represent Sri Lanka. This slide shows the outline of my presentation in the next 20 minutes. Very briefly on the burden of cancer pain, the close relationship between the biopsychosocial aspects of the individuals and the cancer pain experienced, the concept of total pain experience, and finally, how the cancer pain is best assessed in achieving improved or better pain outcomes. The prevalence of cancers, the global and regional experience. According to the World Cancer Report 2020, the prevalence of cancers is rising rapidly throughout the world, and the burden is expected to double in low and middle income countries over the next decade. The WHO report states that more than 60% of the 40 million new cancer cases reported globally in 2012 were in developing regions such as Asia, Africa, Central and South America. The burden of cancer pain. Cancer pain is the most feared and devastating symptom, affecting nearly 66% of cancer patients. As you all know, cancer pain is very complex. A meta-analysis of 122 studies has shown a significant association between cancer pain with anti-cancer therapies and advanced stages of cancers. The study also revealed that approximately 38% of patients among them experiencing moderate to severe pain with pain scores of over 5 on a numerical rating scale. The impact of cancer pain. The prevalence of undertreated cancer pain is relatively high in Asia. It's about 59% compared to 40% in Europe and 39% in the USA. In a study done in Sri Lanka, the pain relief was identified as the most expected need of cancer patients and the reason for most readmissions. Cancer pain is widely misunderstood, underreported, and undertreated, causing significant distress for patients and relatives with a significant negative impact on the physical, psychological, social, and spiritual well-being of patients and their quality of lives. The biopsychosocial model of cancer pain. This slide shows the close interaction between the perception of cancer pain and the biopsychosocial aspects of the individuals. The biological factors such as the extent of tissue injury, genetic factors, the psychological aspects including thoughts, emotions, mood, prior experience with pain, coping strategies, and the socioeconomic status, beliefs, etc. have a direct influence on the extent of cancer pain experienced. Similarly, the patient's response to cancer pain is highly variable, showing multidimensional effects on their well-being and the quality of lives. This slide shows the different responses of patients to pain, comprising of sensory, affective, cognitive, and behavioral effects. The concept of total pain denotes a multidimensional experience of cancer pain, impacting on physical, psychological, social, and spiritual well-being of the individuals. It also acknowledges the role of sociocultural factors influencing the individual's perception of pain and the responses to pain. The need for holistic assessment of cancer pain. The holistic assessment of pain involves the recognition of pain and the understanding of the context in which it is experienced. The biopsychosocial model provides a framework for understanding the diverse nature of pain experienced and hence justifies the need for an overall or holistic assessment of cancer pain. It has been shown that the holistic assessment provides a guide to selecting appropriate multimodal therapies with the potential to improve the outcomes of pain. The holistic assessment of cancer pain. Points to ponder. The pain, being a subjective feeling, is best self-assessed. Recommends to assess the total pain experience by appreciating the impact of biopsychosocial factors on the overall well-being and quality of life of the individual. Use multidimensional tools to assess the pain experience in terms of severity, interference, qualities, as well as patient needs, satisfaction with therapies, self-coping strategies, etc. Assess the pain daily and keep records to evaluate the progress and the response to therapies. Use a self-maintained pain diary, paper-based or electronic, to facilitate pain teams to monitor progress, side effects, and for emergency contact for advice, etc. According to the pain notes of the revised definition 2020 of the International Association for the Study of Pain, the pain is always a personal experience influenced to varying degrees by the psychosocial factors of the individual. Therefore, the pain is best assessed individually. According to the literature, inadequate pain treatment is commonly due to the disparity between the treating doctor's pain estimates and the patient's pain reports. Therefore, self-reporting is regarded as the gold standard of pain evaluation, since it is the simplest and most reliable way to determine the presence, location, and degree of pain. It is also recommended to assess the total experience of pain while appreciating the biopsychosocial interaction and its impact on the physical, psychological, social, and spiritual well-being and the quality of life of patients. Apart from those, assess the patient satisfaction with different therapies, the needs and coping strategies of patients to include in the future management plans, and finally, the impact of pain on the family. According to the literature, the pain is commonly underassessed. Therefore, the pain assessment necessitates a holistic approach that considers all aspects of pain perception and pain responses in the individual patients. The impact initiative on methods, measurement, and pain assessment in clinical trials recommends to assess pain across 6 basic outcome domains. This slide shows the recommended domains of holistic pain assessment, which include the severity and qualities of pain, physical, emotional, social, and spiritual disabilities or well-being, patient needs and satisfaction with treatment, any additional symptoms and side effects of therapies. Recommends to use appropriate multidimensional tools such as short-form brief pain inventory, short-form McGill pain questionnaire tool, along with numerical pain rating scale. They are globally used, simple, user-friendly, and less time-consuming to use. Culturally adapted, translated, and validated versions are recommended. The tools used should be valid, reliable, sensitive, and culturally adapted to guide treatment and evaluate the therapeutic efficacy. As mentioned previously, recommends using multidimensional instruments such as short-form brief pain inventory to assess pain interference and severity, short-form McGill pain questionnaire to assess qualities of pain and their intensity, along with 11-point numerical rating scale to assess severity of pain. Regarding the need to self-assess pain daily and to keep records. According to the literature, pain assessment should be a continuous and a dynamic process to facilitate planning of ongoing care. Impact. The initiative on methods, measurement, and pain assessment in clinical trials recommends the routine self-monitoring of pain in patients with advanced cancer to address critical barriers to pain management. Use of a self-maintained, culturally adapted pain diary for record keeping, either paper-based or electronic versions. The pain diaries are recommended to help pain teams to review daily the pain records maintained by the patients, to eliminate the need for the patients to recall past events and biases in the record, to keep track of incidental pain episodes, changes in the progress of the disease, side effects, etc. They also provide better insight into the effectiveness of pain management and help plan therapies accordingly. Diaries also improve communication between the treating physician and the patient. According to the literature, pain teams may find pain diaries as a benchmark in assessing the progress and adequacy of care. Commonly handwritten, with 4 to 6 entries per day, the number usually based on the episodes of breakthrough pain experienced by the patients. The electronic versions of pain diaries, such as mobile apps, facilitates emergency contact and advice, etc., especially in circumstances where physical contacts are limited during pandemic states such as COVID-19. It has been shown that the holistically assessed pain experience facilitates the use of multidisciplinary therapies and thereby improves the pain outcomes and the satisfaction of patients and their families. So, in summary, the points to ponder in holistically assessed cancer pain include the promotion of self-assessment of pain, the assessment of total pain experience using multidimensional tools which are valid, reliable, and culturally adapted. Self-assessment of pain daily and keep records, preferably using a culturally adapted pain diary. These are my references. Thank you.
Nice presentation. Now the next speaker and the last speaker is for the session, Abdullah B. Abul Khair, Deputy Chairman, Department of Anesthesia, King Faisal Specialist Hospital and Research Center, Riyadh, Program Director of Pain Management Fellowship, King Faisal Specialist Hospital and Research Center, Riyadh. Topic, spinal cord stimulation, a review.
Assalamu alaikum wa rahmatullahi wa barakatuh. This is Abdullah Abul Khair. I'm giving a talk about spinal cord stimulation, a review. This is in collaboration with King Faisal Hospital, Department of Anesthesia, in our cadaveric interventional pain course that will be done at Al Faisal University. I'm a consultant anesthesiologist and chronic pain specialist and consultant, and we'll start this review First of all, we'll start with the definition of chronic pain. Chronic pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage, and who in patients have had this pain for greater than 3 months. Chronic pain affects about 20% of the population in developed nations. In Saudi Arabia, a recent study done and published in the Saudi Medical Journal in 2019 showed that the prevalence is about 46% of the Saudi population complains of chronic pain, and 4% of those have high impact chronic pain affecting their daily lives, with a higher prevalence among women and elderly. Literature supports a multidisciplinary approach as a standard of care through chronic pain patients or to chronic pain patients, although various health care systems may not always support this concept consistently, as resources and available materials may differ from a country and health care system to another healthcare system. However, this type of care for patients provides the most robust care. If we look at the diagram illustrated here, a patient is at the center of care, surrounded by the multidisciplinary or the multiple disciplines that may surround any patient, and then to the outside of that care are the ancillary systems that all play a pivotal role, important role in patient care and improving patient satisfaction. We're very familiar with this diagram. Many patients, this is a multidisciplinary approach is inadequate or ineffectual. It is accompanied by the burden of side effects that are unacceptable and debilitating sometimes. Only at this late stage referral for advanced neuromodulation technique is considered. So patients may go through multiple trials of medication management as well as physical therapy, and spinal cord stimulation may be delayed for several different causes, including but not limited to financial restrictions, as well as insurance or governmental restrictions. Just to go through the WHO ladder quickly, this is the ladder used by oncology or pain management specialists in managing pain. So if you see if a person has persistent pain or a patient has persistent pain, usually the first step is to use non-steroidals, paracetamol or aspirin, plus minus adjuvant drugs. Step 2 would consider using low-dose opioids or low-potency opioids, such as codeine, non-opioid drugs such as non-steroidals and adjuvant drugs. Step 3 would include use of high-potency opioids, non-opioid drug, non-steroidals, adjuvant drugs. Step 4 would go to the interventional treatment, use of high-potency opioids and other adjuvant medications. This stepwise approach has been considered in multiple circles to be ineffectual, but works for maybe certain types of pain. However, other types of pain where an intervention may be considered early or should be considered between step 1 and 2 or between step 2 and 3 before reaching the high-dose opioids. Going through or to the our topic, which is spinal cord stimulation, an estimated 50,000 spinal cord neurostimulators are implanted annually. These are the IPGs from the main companies that we use, and the lead types and shapes, as you see here. The 4 main companies that are used are Medtronic, Boston Scientific, St. Jude Medical, which is now Abbott, and also there are some that I didn't mention, including peripheral stimulators. There are several companies which are Bioness is one of them, as well as Nevro, which is not available. in Saudi Arabia. If you look to the right of this slide, you see several types of lead shapes and multiple different types of contacts, and these have been placed anywhere in the body, where a nerve runs. This gives pain or is thought to give pain, from single electrodes with wide spacing to narrow spacing and more flat electrodes for laminectomies. Or to be placed directly over the brain or over the spinal cord. So where did this come from? Where are the beginnings of spinal cord stimulation? The first recorded use of neuromodulation for the treatment of pain occurred in about 15 AD when Scribinus, after observing that gout pain had been relieved by the accidental contact with a torpedo fish, recommended torpedo fish for the treatment of pain in general. Torpedo fish conducting electrical sensations. On the right here you can see a picture of a torpedo fish. It's kind of this special looking ray down on the right, and on this plate was depicted about the 4th century BC a companion red figurefish plate depicting Narche circa 4th century BC, pointed to by the red arrow. So the evolution through time, Benjamin Franklin showed the effect of the muscle contraction that followed electrical shock in 1774, and then going on to Mary Shelley's Frankenstein in 1816. In her novel Frankenstein, showed that the reanimation of the human body. This is fiction. And then in 1870, Fitch and Heitzig demonstrated that limb movement occurred on stimulating the motor cortex of a dog. In 1874, the first documentation of electrical stimulation of the brain of an awake human was performed by Bartholow. Then we come to these two known fellows. In 1965, the gate control theory was devised by Patrick Wall and Ronald Melzack. This theory states that pain is a function of the balance between the information traveling into the spinal cord through large nerve fibers and information traveling into the spinal cord through small nerve fibers. If the relative amount of activity is greater in large nerve fibers, there should be little or no pain traveling through the smaller nerve fibers. However, if there is more activity in small nerve fibers, then there will be pain. And that kind of gave way to this theory of stimulating the nerve fibers in order to distract the brain from feeling pain, or distracting larger fibers from or sensory fibers in order to not feel pain. Reviewing the types of nerve fibers available, or the ones that are in the body, you have A alpha, A beta, A delta, and then C fibers. So the alpha, beta, and delta fibers, the A alpha, they carry proprioception, myelinated, about 13 to 20 diameters, 13 to 20 micrometers in diameter, and conduction speed is very fast, 80 to 120. And that's for proprioception. For touch, which are beta fibers, are myelinated as well, 6 to 12 micrometers in diameter, and their conduction speed is about 35 to 90 meters per second. Delta fibers, these are pain, mechanical, and thermal, myelinated. These are smaller, 1 to 5 micrometers in diameter, and they conduct pain in about 5 to 40, or conduct sensation of pain in about or in a speed of about 5 to 40 meters per second. C fibers, they are pain, mechanical, thermal, and chemical, non-myelinated, 0.2 to 1.5 micrometers in diameter, and they are slower compared to the rest, 0.5 to 2 meters per second is the conduction speed. So after that, Norman Shealy in 1967, a famous neurosurgeon at Western Reserve Medical School, stimulates the large nerve fibers where they were uniquely gathered in the dorsal columns of the spinal cord for a patient with metastatic lung cancer, and sutures the electrode to the D3 level in the spinal cord to the dura, and provides profound pain relief for this end-of-life cancer case, and ushers in a new era of spinal cord stimulation, or for this kind of experimental case of implanting a lead in a dorsal column. The name of the paper was Electrical Inhibition of Pain by Stimulation of the Dorsal Columns. This is a picture of a spinal cord stimulation programming device that is or was used back in the 90s at King Faisal Specialist Hospital, and it was used early on in the kingdom. However, we have come a long way since this type of device, and they're become smaller, sleeker, and more advanced. The four main companies that are covering spinal cord stimulation nowadays are, if you see up here on the left, are the Boston Scientific with a multitude of electrodes and IPGs and programming and devices, as well as the St. Jude Abbott, Medtronic, long-standing company in Saudi Arabia, the oldest, as well as Stimwave, which has ushered in a new type of spinal cord stimulation, and as well as some newcomers, Bioness, which provide peripheral stimulation. We're still to implant or see the first implant for Bioness in the country. However, we're looking forward to applying this new technology. The original term of dorsal column stimulation has evolved to become known as spinal cord stimulation going forward. Mechanism of action. Although the exact mechanism for pain control from spinal cord stimulation is not entirely understood, it is believed to result from direct or facilitated inhibition of pain transmission. The mechanisms of spinal cord stimulation include the gate control theory, segmental antidromic activation of the alpha to beta efferents, blocking transmission in the spinal thalamic tract, supraspinal pain inhibition, activation of central inhibitory mechanisms influencing efferent neurons, activation of central inhibitory mechanisms influencing sympathetic efferent neurons, activating putative neurotransmitters or neuromodulators. So what are the main types of stimulation or types of wave forms that we see in these spinal cord stimulators? So we look at A first. This is a tonic stimulation, frequency usually between 40 to 50 hertz, amplitude between 2 to 4 MA, and a pulse width of 200. The type B here is a burst stimulation. And burst stimulation, burst spinal cord stimulation, series of 5 1,000 microseconds pulses at a frequency of 500 hertz, interspike interval of 1,000, and each train repeated at 40 hertz, cumulative charge of 5. Spikes is charge balanced passively and immediately after the burst of 5 spikes. When it comes to high-frequency stimulation, the high-frequency spinal cord stimulation frequency at 10 kilohertz, amplitude of 2.2 milliamperes. What are some of the commonly accepted indications for spinal cord stimulation. I'm going to go through this slide one by one. So the common indications include post-herpetic neuralgia, intercostal neuralgia, post-laminectomy pain syndrome, and cauda equina, chronic injury syndrome, chronic arachnoiditis, complex regional pain syndrome of the upper, lower limbs, and other specified sites, phantom limb pain, cardiovascular angina or ischemic pain, atherosclerosis of the extremities with resting pain, peripheral vascular disease, brachial neuritis or chronic cervical radiculopathy, thoracic or lumbosacral neuritis or chronic radiculopathy, cervical nerve root injury, thoracic nerve root injury, and lumbar nerve root injury. So what are some other potential indications? Include chronic occipital neuralgia, chronic pelvic pain, deafferentation pain, axial pain, thoraco-abdominal aortic aneurysm pain, cerebral palsy, multiple sclerosis, spinal cord injury. So multiple indications, multiple different types of patient populations. Commonly accepted contraindications, so absolute, include patients that are septic, coagulopathic, previous surgery or trauma that obliterates the spinal canal, localized infection at the implantation site, or spina bifida over the implantation site, or if it's for a lumbar indication. Commonly accepted contraindications or relative contraindications include physical and or cognitive psychological disability that interferes with proper usage and or understanding of the device, significant somatization, somatoform disorders, unmanaged substance abuse or cognitive disorders, and lack of social support. One of the interesting concepts I've seen in the past, as some countries will not implant a full system unless during the trial phase, the patient that is on chronic opioids or high-dose opioids weans completely off of the opioids during the trial phase, which is about 3 to 4 weeks. And then if this is proven or the patient is able to do this, then a permanent lead or an IPG will be implanted, and the lead will be kept in place. So how do you go forward? One of the most important things is proper patient selection and preparing or in doing these cases. It's essential in long-term success. Improved hardware and patient selection increase the long-term efficacy of spinal cord stimulation to approximately 70%, up from approximately 40% since the 70s and 80s. What is the definition of long-term efficacy? So it's long-term reduction in pain, reduction in opioid medication consumption, improvements in activity of daily living, and return to work status. You can measure this by using different types of functional questionnaires that are available and have been validated into the Arabic language. I recommend implementing these into your pain clinics when you are working there in the future or currently. So some of the selection criteria should be considered for patients who have failed all reasonable conservative care, given a reasonable period of time to recover, about 6 to 12 months from surgical intervention, conservative pain relieving minimally invasive treatments and or failure of surgical treatments with persistent extremity pain greater than axial spine pain. They tend to work better for extremity pain than for axial pain. The other aspect of this which is a recovery period time. Also there's some transitional pain clinics that are starting up currently, and they are following into the use of temporaries, peripheral stimulators to transition patients from the perioperative painful period into the postoperative period where the pain has improved, and they decrease the use of postoperative opioid, therefore decreasing the amount of patients addicted to opioids. So what type of patient are we looking for? So we want a patient that is, motivated, compliant, free of drug dependence. I mean, ideally, psychological screening is recommended. You want to rule out any kind of major psychiatric disease or illness, such as major depression or anxiety, bipolar disorder, anything that is may affect the success of your implant or your intervention. Typical indications for this procedure include, as we mentioned in the past, chronic radiculopathy, perineural fibrosis, neuropathic pain, and complex regional pain syndrome. Extremity pain responds better than axial pain, and the more distal the extremity pain, the greater the clinical response. So this is the ideal patient and kind of a depiction of how closely you should be related or know your patient. So usually these types of implants go into two phases. There's a trial phase and then an implant phase. So phase 1 and phase 2 you will commonly see. The percutaneous trial is the use of an outpatient percutaneous trial of between 3 to 7 days. This is a method used commonly in North America with a spinal cord stimulator system, has been proven helpful in determining which patients will respond well enough to warrant a permanent spinal cord stimulator implantation and determine the future permanent implantation levels. Some physicians believe that this is too short of a time to determine a successful trial, and in Europe they are more towards the phase 1 trial of about 3 to 4 weeks. So you would see the phase 1 trial being done or conducted with a permanent anchoring system, and then tunneled out to the side. Patient is brought back in about 3 to 4 weeks, and if the success, what they've noticed is their trials, due to their specific selection criteria, have been very successful. So their conversion to full implants is about 90%. So they rarely have to go back and take out the leads. A positive trial should include tolerance of paresthesia, more than 50 to 75% of pain relief, and overall patient satisfaction. Relative requirements for a positive trial include improved functional levels, reduced usage of pain medication, and reduced reliance on the healthcare system. So this is a form from Blue Cross Blue Shield indicating the needed criteria to be fulfilled prior to implanting a spinal cord stimulator. I will go through this quickly. You need a pre-authorization by the plan is required to, prior to the stimulator being dispensed by the vendor, and a documented care plan indicating the stimulator use and expected outcome must be submitted by the physician, and spinal cord stimulator, central nervous system stimulator, dorsal column are covered when all of the following criteria are met. So therapy consists of a short trial with a percutaneous implantation of neurostimulator electrode in the epidural space for assessing a member's suitability for ongoing treatment, and a permanent surgically implanted nerve stimulator performance and documentation of an effective trial is required for consideration of a permanent nerve stimulation. And the implantation of the stimulator is used only as a late or last resort of for patients with chronic intractable pain. Other treatment modalities, including pharmacological, surgical, physical, and or psychological therapies, have been tried and did not provide satisfactory pain relief, were judged unsuitable, or were contraindicated for the patients. Member has undergone appropriate psychological screening and or diagnosis by a multidisciplinary team before implantation to include patient education, discussion, disclosure, including an extensive discussion of the risks, benefits of the therapy. All the facilities, equipment, and professional support personnel required for the proper diagnosis, treatment, and training and follow-up of the patient are available. All trials which proceed to permanent implantation should demonstrate adequate documentation to support the decision. A successful trial should be associated with 50% reduction of target pain or 50% reduction of analgesic medications and show some element of functional improvement. Patients with reflex sympathetic dystrophy may show lower levels of improvement, since it takes longer periods for improvement than the typical 1 to 2 weeks. This is a picture of the percutaneous trial. Usually it's placed with a epidural needle. I have a video here to show you, so I'm going to pause and then jump to the video. So hopefully you were able to watch that video. It's about 8 minutes long. I recommend watching it before you join the workshop on Saturday. The next part of the lecture also talks about the postoperative care. So once the patient is awake and alert in the recovery area, the patient's spinal cord stimulator settings should be optimized. The adjustable parameters are frequency, pulse width, and amplitude. Increasing the pulse width increases the density of the stimulus, which provides for deeper penetration into the spinal cord. The amplitude represents the electrical force of the stimulus. During the recovery period, the spinal cord stimulator programming is fine-tuned. The patient and/or patient's family is educated on how to use the device, and any questions are answered. Post-procedure care as well include the spinal cord stimulator area should be clean and dry, and specifically told not to bathe or shower, but to take sponge baths during the trial period. Prophylactic oral antibiotics are provided, and some areas of the world don't provide any oral antibiotics. They will give 1 dose of IV antibiotics intraoperatively of a broad spectrum antibiotic such as cefazolin, and then in the postoperative period will not provide oral antibiotics. And the patient is instructed to avoid excessive bending or twisting, as this may dislodge the spinal cord stimulator lead. After that, the patient will come back for the permanent implant. We will demonstrate this on our workshop on Saturday, and the way this is done is if the patient has a percutaneous trial lead which is anchored to the skin, the trial lead will be removed in the clinic or in the outpatient setting. Then the patient will be brought back for the first and second stage to be done at the same time in the operating room or in the procedure room that is set. A lead will be placed at the same level that was comfortable for the patient and provide the same stimulation, preferably 2 leads to provide a larger area of stimulation, and then they will be anchored and then stitched in place. Tunneling device used to tunnel into the pocket will be used, and IPG will be implanted. Some of the common complications associated with spinal cord stimulation. You have 2 major types of complications, including hardware-related and biological complications. The hardware-related complications most commonly include lead migration. Peripheral leads have been reported to be migrating at very high rates, as high as 100% have been reported in the literature, and this is why they have recommended use of a strain relief loop. For neuroaxial spinal cord stimulation, leads migrate 10 to 25% of the time. Most common complication of spinal cord and peripheral nerve stimulation is lead migration, possibly more common in the cervical compared to the lumbar because of its a high mobility area. Lead fracture and malfunction is reported as 6 to 9%, as you see in this picture showing the tip of the lead has fractured and migrated as well. Battery failure, 2 to 10% premature depletion has been reported as well. Higher stimulation has been linked to this. High frequency burst uses more battery power, and rechargeable devices may be more practical but may need to be charged daily. From the cost effectiveness standpoint, clinical as well as modeling studies have suggested that implantation of a rechargeable system is indicated mainly when a cell-driven device lasts for less than approximately 4 years. Pain related to device component or implantation is reported in 1 to 25%, more usually with the IPG implantation area. Wound infection, superficial and deep, have been reported, and wound breakdown, 4 to 10%. In a study reviewing 114 cases of infection, they reported that 48% of cases were due to staph and 3% were due to Pseudomonas. Generator pocket site was the most common site of infection. Skin erosion is rare, 0.2 to 7%, more commonly with peripheral stimulators. Other complications include dural puncture, 0 to 0.3%, neurological injury, 0.3%, in one case reporting a epidural hematoma. Those were the biological complications. Factors affecting the rate of occurrence of complications. The location of the lead. Position of the lead is in a relatively immobile location of the spine, decreases migration. In the thoracic region, 7.8% versus lumbar, 27%. Strain relief loops and extensions decrease this complication. Higher migration rates with peripheral nerve stimulators, occipital nerve stimulators, in the tune of 13 to 31% respectively. Operating surgeons experience and hardware used play a role in the rate of complications. So what is the level of efficacy of spinal cord stimulations or spinal cord stimulators? So there is level 1 and level 2 evidence for spinal cord stimulators as a treatment for lumbar post-laminectomy pain syndrome, previously called failed back surgical syndrome, where conventional medical management has failed. Level 1 evidence for high frequency stimulation, only limited evidence for burst stimulation. Tolerance was found in one study done over 10 years, around 30%, not with high frequency stimulation. Cost efficacy studies show that despite significant initial costs, spinal cord stimulators results in long-term reductions in healthcare costs, which offset the high initial treatment costs over time. So in summary, significant evidence exists for traditional spinal cord stimulators as a safe, clinical, and cost-effective treatment for many chronic pain conditions. There is now level 1 evidence for newer techniques, including high-frequency spinal cord stimulators and dorsal root ganglion stimulators, which demonstrate dramatic improvements in overall efficacy in reducing pain in specific conditions, including failed back surgery, back pain, neuropathic leg pain, complex regional pain syndrome, and causalgia. The data supporting spinal cord stimulation in its multiple forms are compelling and have reached a level that now demand that this therapy be considered earlier in the treatment continuum and to be no longer regarded as simply an end-stage salvage therapy. Some MCQs. So a 34-year-old woman with post-laminectomy syndrome undergoes a spinal cord stimulator trial. During the procedure, the patient suffered an inadvertent dural puncture. Which of the following treatments will most likely decrease the incidence or severity of post-dural puncture headache? Bed rest for 60 minutes after the procedure, hydration with 2 liters of normal saline, sumatriptan, thiophyllene. One of the interesting cases that we have, both lumbar and thoracic spinal cord stimulation, and a patient with cervical stimulation, have both gone back and forth, have had multiple implants in the past, and done very well. So at this point, I invite you to send me any questions via email or by message. I'm sorry this lecture is recorded for the time constraints that we have. Thank you very much for listening, and I hope to see you on the workshop or in the workshop on Saturday. Thank you.
Thank you for your nice presentation. And this is the end of session. And I would like to thank President Professor Debabrata Bonik sir and General Secretary Kausar Sardar sir for arranging a second international conference on pain, BSA CCPP 2022, and 7th international conference on recent advances in pain, ICRA ICRA pain. And goodbye and Allah Hafiz. Thank you.